My name is Greg Caronis. I'm a community orthopedist in Lake County, Illinois. The main hospital where I go is Advocates Condell Hospital, which for the last 4 years or so has been Lake County's only level 1 trauma center. And as a result, we tend to see a fair number of pilon fractures, also known as plafond fractures. One of the questions I'll often get from patients is, where did this name come from? We all know that pilon fractures or plafond fractures are fractures of the distal tibia. Pilon is a French derivation from pestle, as in the mortar and pestle, and plafond is an English word referring to an elaborate ceiling. We know it's a fracture of the distal tibia, often of higher energy than a routine ankle fracture, and it's often intra-articular. This is a slide just showing some very basic anatomy of the ankle. This is the distal tibia, and this is the bone that we're interested in today. If one goes back to that English word where it talks about being a beautiful ceiling, if you think about it, it's the ceiling for the ankle joint. But this is some very basic anatomy showing the distal tibia, the fibula, and its relationship to the talus over which it sits, rather. Pilon fractures aren't terribly common. They occur in less than 10% of lower extremity injuries. And typically these patients tend to be younger, usually in the age range of 25 to 50. There are two basic mechanisms of injury. One is a more high energy mechanism. In a high energy injury, the load is applied very, very quickly. There's a large amount of energy that's dispersed into the soft tissues, causing a significant soft tissue injury, in addition to a very significant bony injury. Examples are a fall from a height, from a ladder, for example. Motor vehicle accidents are another way. With the advent of airbags, we tend to see more of these than we used to. More patients are surviving at the scene and are being brought into the hospital with these sort of injuries that are being managed nowadays, which weren't 20 years ago. In low energy injuries, the load is applied much more slowly. There's relatively little energy applied to the ankle. The soft tissue injuries tend to be much more minimal. The bony injuries tend to be less comminuted or less fragmented. These were initially classified by Rudy and Allgauer back in the 60s. Their classification system consisted of the injuries on top, which they described as being essentially undisplaced fractures of the distal tibia. Mildly displaced ones were called level 2s, and severely comminuted ones where there were multi-fragmentary injuries involving the joint were type 3 or comminuted injuries. More recently, the Orthopaedic Trauma Association has changed this somewhat. Type A's are extra-articular fractures where the fracture line never enters the joint. Going from 1 to 3, the bony injury tends to be more comminuted. In type B, they enter the joint in a partial manner. Going from 1 to 3, again, it becomes somewhat more comminuted or fragmented. And in type C's, it's considered total articular, where there's much greater involvement of the articular surface. When one assesses these injuries, it's important, we always get a good history, and it's very important. And one of the first pieces of information one will want to get is how high of energy mechanism was this, because this will determine how severe the injuries and what sort of landmines lie in wait for you. Other injuries may occur in a higher energy injury. For example, these patients may have neurologic or head injuries. They may have visceral injuries to their abdomen or chest. Compartment syndrome may occur, but not terribly often. Only depending on which study you read, only up to 5% of these patients sustain compartment syndromes. One also wants to assess for comorbidities. Alcohol is important because it can compromise healing. It may lead to you having a compliance issue with your patient. Whether when one smokes or is malnourished or has peripheral vascular disease, that all speaks to one's healing potential. Smokers, people who are malnourished, people who have poor blood supply are going to have more issues as far as healing these injuries. If you assess these patients and they have some element of osteoporosis, that will imply that you may have more challenges in stabilizing these fractures. On examination, the key thing to really treating these injuries is to appreciate what's going on with the soft tissues. First of all, when you look at these patients, is this an open or closed injury? An open injury, of course, would demand that something be done more immediately. You want to get a sense of how swollen these people are. If one is seeing these on a more delayed basis, there may be blistering of the skin, either clear or blood-filled, but the amount of blistering you see is also an indication of just how much energy these patients sustained and how traumatized these soft tissues are. Again, you'll want to assess for compartment syndrome, and you want to get a sense of alignment of these sorts of injuries. If one has a very crooked ankle, it can lead to tenting of the skin and lead to a delayed compromise in the skin where they develop erosions or ulcers in the skin. One will initially want to x-ray these with good biplanar films. Those are a great starting point. If one looks at the film on the on the left, one can see that there's one fracture line. This is an extra-articular injury that's well aligned, and one can get the sense that this was a fairly low energy injury. On the other hand, if you look at this one on the right, one can see that there's very significant displacement. The fibula, in addition to the tibia, is fractured, and one can see there are multiple fracture lines that extend into the joint. And finally, you'll see this when you examine patients. You'll see a crooked leg, but you can see why, because the tibia is tenting the skin over here because the foot's been translated laterally. And over here, if one doesn't provisionally reduce this sooner than later, they can erode through the skin, and suddenly one has an open fracture to contend with. CT scans are really critical and very key in managing these injuries. It gives one a three-dimensional representation of the fracture. You can see all the fracture lines that are present, and it really gives you a good appreciation of what the joint and the articular status is. It's really important for preoperative planning. It'll dictate what approach you'll use. That will often have input as far as what sort of implants one will want to use in fixing these. I would put out to you that it's not possible to consistently manage these injuries well without the information you'll get from a CT scan. This is an example of one where we have x-rays and CT scans to compare, and if one looks at this plain x-ray, if you look at that joint surface, it really doesn't look that bad, but one can get a sense that there are some fracture lines here, and the fact that the fibula is off 100% implies that there's probably more going on than the x-rays indicate, and that's where the CT scan becomes critical. If you look up here in the distal diaphysis of the tibia, this is really fragmented into multiple pieces. If one looks at the joint, here it looks pretty good, but look right here, you've got this large chunk of the joint surface that's not in an appropriate position, which will compromise long-term function. One can see here on the right a three-dimensional reconstruction, and I think for most orthopedists it's not crucial to have it. It's kind of nice eye candy to show your patient, to show what all the fracture lines look like. This is another example where a CT scan is really very, very helpful in truly delineating this fracture. Obviously, if you look at these x-rays to the left, this distal tibia is really shattered into multiple pieces. You have a portion of the tibia that's just completely disengaged from the rest of the tibia. But if you look at the joint, your initial thinking is that it's not too bad. But when you look at the CT scan, here's a big piece of the joint surface that's completely rotated and out of place, that's also well appreciated on these cuts. So it really helps one appreciate where all the pieces are and what tasks one has to do when they attack these in surgery. Initially, after looking at these, after you do an initial assessment, you really have to look inside yourself and decide, is this something I can handle? Is this something I can do? And if not, it's really appropriate to get it to somebody who should. To quote Dirty Harry from Magnum Force, a man's got to know his limitations as far as what they can and can't do. How do we treat these? Well, there is a role for close treatment of these injuries. We looked at this slide earlier, and this is essentially a very well-aligned, low-energy injury of the distal tibia. And this is one that can very appropriately be managed with closed treatment. Initially, typically one will put a splint on, wait several days for the swelling to peak, and then apply a cast. And after 6 or 8 weeks, the cast is removed and they can be rehabbed and generally can be expected to have a reasonable outcome. Surgical treatment is often entertained on these. Historically, external fixation had a very huge role for definitive management of these injuries. And one could manage it with a joint spanning fixator, articulated fixators where there was a hinge here in the ankle that would allow some motion were very, very popular in the 90s. Ring fixators had very huge application as well in the 90s, though it's fallen out of favor somewhat in more recent years. The advantages of external fixation for these injuries was it really minimized the additional soft tissue injury one could inflict on these patients. And technically, it was a little easier to do than fixing these with plates and screws. On the downside, when one spanned the joint, there were very significant limits on how much motion one eventually got. And if all you do is apply an external fixator, you're not doing anything to reduce the joint disruption. Internal fixation with plates and screws has a great advantage as far as one's ability to truly put the joint back to where it should be. The disadvantage historically was that it led to additional soft tissue trauma, which led to a fairly high incidence of wound healing problems and infection. In the 80s and 90s, we saw that in the United States significantly. Currently, most of these injuries, the severe high-energy pilon fractures, are managed in 2 stages. The initial stage is application of an external fixator. There's some controversy as to whether or not one should fix the fibula at that time or on a delayed basis. Some authors feel that the advantage is you apply more stability initially. Some authors feel that there can be some wound healing problems. The other disadvantage is if you don't do the fibula properly the first time, it really impedes what you're trying to do at the next step. Where the fixators help is in managing these is to help, first of all, manage the soft tissues. If you look at this patient's leg right after the fixator is applied, you can appreciate how shiny and tense the skin is. If you try to operate on that initially, you can almost count on having wound healing problems. By just putting the fixator on and letting the soft tissues rest, you can see that after a week, the swelling is significantly less, and it makes for a much safer task as far as addressing this with open incisions. This is another example of a patient who has fracture blisters initially that occur after this. The fixators are on with the idea that you just let the soft tissues quiet down and heal up. You let the blisters resolve, and then you get to something like this where now the swelling is down, the skin wrinkles, the blisters are gone, and it's a much safer environment in which to operate. The other role of the external fixator initially is that it helps your reduction. This is initial film done in the ED, and one can appreciate how the talus has just been driven up in the tibia. And you're not always sure as to what you're looking at, but once you put that fixator on, you can see that you go from this where it's really poorly aligned to one where it's much better aligned. And at this point is where one gets a CT scan that makes a little more sense, and you can much more easily institute an operative plan. Again, to sum this up, after you apply an external fixator, you temporize the soft tissues, you can get patients out and they can get rid of their swelling at home and out of a hospital setting. You improve the reduction, you can get a CT scan that makes it easier to work with. When do you want to operate on these? Well, you want to wait for the soft tissues to improve. It can be as short as 10 days, but in some series, it can take 3 weeks or more. Again, your goal is to allow the soft tissues to heal so it's safer to work with them. The swelling's gone, the blisters go away. And then you can get to this where you're applying your internal fixation. There are various approaches one can use. One can go anterior, anterior lateral. There are certain reasons to go posterior. The approach one chooses is really dictated by the injury as you see it on the CAT scan. So again, That speaks to the importance of having a good CT scan and going in with a plan before you start the case. Knowing what the CT scan looked like will often dictate what implants you want to use. There's been a move over the years to go from large bulky implants to ones that are smaller and lower profile. Instead of using one implant to be your workhorse, it's not uncommon for multiple implants of smaller size to be used. Locking plates in the last 10 years have come in vogue. They have a more especially significant role in patients who have osteoporosis. Post-operatively, after one treats these, I'll typically, in my hands, I'll splint them for several weeks, again, to allow the wounds to heal, then get the stitches out at that point. I like to get people into a boot at this point and start some early mobility, but I'll keep them non-weight bearing for a good long stretch, 8 to 12 weeks, until I'm fairly certain and confident that the tibia is healed. Are there reasons not to do open surgery? And the answer is yeah, absolutely. If you have patients with poor quality soft tissues with significant breakdown, those are ones where you might just choose to definitively treat them with an external fixator long term. If you have a patient with really poor healing potential, vascular disease, heavy smoker, diabetics, those are ones to really think about whether or not those are people you want to put incisions on, because those are going to be your really challenging ones and may get into trouble. What complications can you see these? I'm sure for most of you who've been doing this for a long enough time, you've seen all these complications. Wound healing problems being chief. This is one study from the early 90s from Teeny and West. They saw 37% of their patients get infected, and some series go up to 50%. The best thing you can do is just avoid having that happen. You'll want to be very careful and judicious about timing your surgery, allowing the soft tissues to heal. And when one operates on these, it's really important to use very careful and meticulous technique in handling the soft tissues. If one develops early breakdown, it's important to address this early. You can't just sit and look at this in the clinic every week and expect it to change. You have to be proactive and debride it where it's necessary. The other thing that's really helpful in treating this is to have a good relationship with one's local plastic surgeon. It has to be a plastic surgeon who wants to do more than just cosmetic work. It's very easy to get in trouble with these, and if you can't get somebody to help you cover these, it's a really big challenge. So again, it's important to treat these at a place where you have good plastic surgery support. If one develops a deep infection, there's no other way to get around this. The hardware has to come out. Patients have to go back into an external fixator, and they need to be on IV antibiotics. Both antibiotic beads or a block spacer can be very helpful as well. And one will often need to go back and bone graft these later and leave a fixator on till union. In some cases, you can go back and fix them with plates and screws. Very, very rarely, if you can't get control of the infection, patients can lose a limb. Non-union happens, not insignificantly, about 5 to 8% of the time, and you can expect that incidence to be higher in your immunocompromised patients, your smokers, your diabetics, and the treatment for it is bone grafting. Post-traumatic arthritis can be expected to occur in the majority of patients, greater than 50%. Eder in the early 90s looked at these patients and found that just because one had radiographic evidence of arthritis didn't necessarily condemn them to significant symptoms. And the treatment for the symptomatic patient typically is anti-inflammatories, injections, AFOs, and rocker bottom modifications to the shoe. Outcomes, how do these patients do? Well, in the low energy injury, one can expect that these patients can do reasonably well. It's the high energy patients that have problems. Dr. Marsh from Iowa published a study in Journal of Bone and Joint Surgery where he looked at 35 fractures in 31 patients. And what he found was that, first of all, patients tended to get better over a prolonged period of time. That's not 6 weeks and they're done. They saw improvement in patients for over 2 years. When they looked at their SF36 scores and ankle arthritis scores over time, these patients tended to decline, as one might expect. They had limitation in their recreational activities. Interestingly enough, relatively few people needed additional surgeries like fusions or hardware removals. In this series of 31 patients with significant injuries, only 5 of them needed a fusion and only 2 needed hardware removal. Dr. Williams in Clinical Orthopedics in 2004 found that, like Etter study, arthritis didn't necessarily affect one's clinical outcome, and what he found was that people generally did poorer when they came from a lower socioeconomic status, had a workers' comp claim, and had a lower education level. This is new? Okay. Dr. Pollack had another series in Journal of Bone and Joint Surgery in 2003, 103 patients. When they looked at age-matched control, their short form 36 scores were poor. 43% of these patients remained unemployed. If you had two or more of the following, being married, being poor, not having college education, and were treated with external fixation, these patients did poorer. I took out this graph from this paper, and they looked at their SF36 scores for various conditions, and having a higher score is better, having a lower one is worse. The general population had a score of greater than 80. People with pilon fracture were significantly worse. And when you really start looking at this, you can kind of appreciate how severe these injuries are. Not many groups did worse. Spinal injuries, dialysis patients, nursing home patients did worse, but look who felt better about their outlook. People with recent heart attacks. People with AIDS felt better than people with pilon fractures. What does that say? Think about it. It's almost saying you'd rather have AIDS than a pilon fracture. It's a significant injury. The bottom line is these are severe injuries. It will impact one's quality of life and their livelihood going forward. It often leads to a change in their lifestyle and their occupation. In summary, these are very complex injuries of the distal tibia. The outcomes are determined by the energy imparted to the soft tissues and the bone. The current management is, for most cases, to treat these high energy injuries in 2 stages, applying a fixator first, allowing the soft tissues to heal, and then providing more definitive treatment several weeks later. These high energy injuries will have a long-term significant impact on one's lifestyle and livelihood.